6 distinguished surgeons compare therapeutic approaches to common complications in surgery on this issue of Audio Digest Surgery, Volume 17, Number 16, the week of August 26, 1970. Moderator for this program is Curtis P. Arts of the Medical University of South Carolina, and guest discussants include Joel W. Baker of the University of Washington and President of the American College of Surgeons, speaking on complications of biliary tract surgery, George A. Hallenbeck of the University of Alabama on complications of gastric surgery, William H. Muller, Jr. of the University of Virginia on cardiopulmonary complications in surgery in the aged, and William R. Sandusky of the University of Virginia on infectious complications in general surgery. Dr. Arts, will you begin the program now, please?
I always get in trouble in this country when somebody comes up and said, "Oh, yes, that Dr. Arts, he's that fellow that had so many complications he had to write about them." Well, we do have some people in the vernacular that have been there, and I think you're always glad to hear from people like that. First, Dr. Hallenbeck, will you talk about complications of gastric surgery?
I think perhaps we could approach this by dividing them into the complications that occur quite early after the operation and those that come along later. Of the early ones, I think failure of the stomach to empty after whatever operation is done as gastric surgery is one of the commonest ones. And although I don't know that it's been proven, I believe one of the causes of this sometimes is that the stomach manages to get greatly over-distended at some point early in the post-op course before perhaps it's decompressed. And if this occurs, and it's a little more likely to occur if a vagotomy has been done as part of the procedure, it can take the longest time before the thing will regain its tone and start to function properly. Whether cholinergic drugs really help or not perhaps is not proven, but I have the impression that giving urocholine has helped some of the patients that I've seen in this category. It seems to me that one of the most important features in management of this complication is not to be in too much of a hurry to go back in and operate, because although it may seem, even on barium study of these stomachs, that nothing seems to leave the stomach and there must be a mechanical obstruction, it is interesting how many times there isn't any mechanical obstruction. Mechanical obstruction can occur, but it's interesting how often there isn't any mechanical obstruction, and just a little more time and patience is what's needed. And sometimes one has to wait as long as a couple of weeks before these things will open up. Another complication of the Bile-Roth 2 type of partial gastrectomy, of course, is leakage from the duodenal stump, which, if it occurs, tends to be about a week after the operation. And I think that the conservative as opposed to operative treatment of this is probably still best, consisting, of course, of some kind of catheter suction drainage if a drain wasn't placed at the time of the operation. And the main points are those of keeping the material that comes out of these leaking stumps, which is very much digestive, keeping it off the skin and protecting the skin during the time that the leakage is healing. Thinking about some of the things that can happen later, perhaps one of the commonest is recurrent ulceration after an operation done usually to prevent just that. And there are a variety of causes of this complication. In operations in which vagotomy is a part, I think incomplete vagotomy is probably one of the commonest causes. If one happens to do the Bile-Roth 1 procedure for ulcer, perhaps a gastric ulcer, and the mistaken idea that it's a primary gastric ulcer when really it's part of the duodenal ulcer diathesis, and if one doesn't do a vagotomy with it, the incidence of recurrent ulceration is quite high. And then if doing a Bile-Roth 2 operation, it's now known how important it is to remove every bit of antral mucosa, because if one leaves a little stump of antrum, of course, it sits there putting out gastrin all the time and stimulating the remainder of the stomach to make acid, and finally ulceration will occur. And another cause of this, of course, could be the Zollinger-Ellison syndrome that simply wasn't evident at the time the first operation was done. I think an occasional instance of recurrent ulcer comes in that circumstance. Now, of other late complications, there's a long list of them, and I would recommend to you issue of current problems in surgery. Linwood Harrington up in Nashville, who does such a beautiful scholarly job, I think, of reviewing literature and presenting things in a clear way, wrote this edition of this paper-bound journal, and it's really fine. We could list some of the things that can occur and occasionally require treatment, but perhaps before doing so might state that, at least in this country, the number of times surgical treatment is being used for the sort of complications I'm about to mention seems quite small. We seem to be dealing way down in about 1% of the people who undergo gastric operations. There can be afferent loop syndromes after the Bile-Roth 2 procedures, in which there is some obstruction to the afferent loop. This can result in a form of bilious vomiting, and there are a variety of ways of correcting this, depending on what the problem really is. Conversion to a Bile-Roth 1, which would seem to be the obvious way of doing it, apparently doesn't work regularly, and this must be because some things thought to be afferent loop obstructions are not really that, but are some other form of complication, I think, such as bile gastritis, which is not corrected ordinarily by just getting rid of the afferent loop. And in Dr. Harrington's experience, interposition of a 10 to 20 centimeter length of isoperistaltically placed jejunum between the stomach and duodenum has worked best in this group of patients. And of course, one must have a vagotomy in the entremont before doing this, or it would be a most ulcerogenic procedure. Efferent loop obstruction occurs sometimes, and the treatment is as indicated by what the problem turns out to be. The early dumping syndrome, most of the people who have this can be managed without operations, and whether we do enough procedures for this or not, I really don't feel that I know. Although several procedures have been tried, some of them rather complicated, making pouches of jejunum to interpose between stomach and duodenum. Again, Dr. Harrington's observation is that an antiperistaltic, in this case, a 10 to 12 centimeter piece of jejunum interposed between stomach and duodenum has given him the best results. The post-vagotomy diarrhea, which in perhaps 1 or 2 or 3% of cases need some sort of surgical treatment, has been managed, apparently successfully in some cases, by putting a similar antiperistaltic loop of jejunum, but placing it not between the stomach and the duodenum, but about 50 to 100 centimeters beyond the ligament of Treitz, just simply reversing it 90 degrees. And this is said to work rather well in some people's hands. Lastly, the bile gastritis problem is one which comes up very late after gastric operations, many years usually, and can give a continuous burning pain that's relieved by absolutely nothing. And those who have handled this by procedures that prevent completely bile from going back into the stomach say the pain will be relieved the next day after such a procedure is done in rather dramatic fashion. The use of Roux-Y loops has been advocated by some, and interposition of isoperistaltic bits of jejunum by others.
Now, Dr. Baker has just gone over some of the results up in the Northwest after cholecystectomy, and we'll talk about complications of biliary tract surgery. Dr. Baker.
We have recently reviewed 1,500 consecutive cases of cholecystectomy, approximately 1,500. However, I shall deal only with the complications, really the early complications, which means those that occurred in the hospital or within 6 weeks following operation. We had an incidence then of morbidity of 7% and a mortality of 0.9%. While delayed complications are really not part of this panel for completeness, so I might just quickly note that there were in this, which amounts to 4 to 14-year follow-up, 16 common duct stones overlooked or recurrent, no strictures, cholangitis 2, cystic duct stump, it was thought to be symptomatic in 3, one with a neuroma, one with a stone, and incisional hernia. I have divided these early complications into 2 categories. One, those arising in the surgical field, which we have to presume represents somewhat an imperfection in technique or a lack of attention to detail or maybe a misjudgment. We have to blame ourselves, I think, a little bit for complications that arise in the field. This may be a little harsh sometimes. And then those complications arising outside the surgical field. They're just about equally divided. The mortality is a little higher in the latter. It is interesting, I think, that whether cholecystectomy alone or with operative cholangiogram, the morbidity was the same percentage-wise in both instances. But when the common duct was explored, the morbid incidence jumped a little bit better than about 2.5 times to 13.5%. However, if this is broken down, it's interesting that when the common duct exploration was negative, the complication rate was just about the same as the rest of them. But it's only when it was positive that this complication rate jumped up to pretty near 20%, indicating it wasn't the surgeon particularly, but it was the disease in the common duct that we have to blame for the increased morbidity. Now, this does raise a question then, can operative cholangiography reliably substitute for diagnostic open exploration of the common duct? It's a good question. Will its routine use eliminate unnecessary negative explorations without missing stones or without missing fibrosis of the sphincter of Oddi? Being addicted to routine cholangiography, I would say that we can answer all these in the affirmative. Now, arising in the field were these 53 complications, which gave an incidence of 3.4% morbidity and a mortality of 0.34%. But since pancreatitis occurred in 7 instances and 2 of them fatal, I'd like to talk a minute on pancreatitis. We don't know, of course, the etiology for pancreatitis is probably not always the same, actually. Some of the accepted factors are the blockade of the ducts, the pancreatic ducts, by stone, spasm, stricturing metaplasia, or by reflux of bile if infected in or under pressure. Other factors following surgery may be interference with pancreatic blood supply, vasospasm, surgical trauma, or thrombosis. But following biliary tract surgery, we have also to consider the traumatic instrumentation of the ampulla and the sphincter of Oddi. We have pressure reflux from operative cholangiography. And of course, as in any postoperative case, we have the postoperative spasm from pre- and postoperative narcotics. And these, I think we should remember, the hazard becomes greater if we're still giving these narcotics when we begin feeding the patient, because I think Dr. Hollenbeck is one that has shown that the post-feeding pancreas that's laden with enzyme is more susceptible to pancreatitis from ligation, for instance, than is the ligation of the empty starvation pancreas. Now, of these 7 cases of postoperative pancreatitis following biliary tract surgery, 2 were associated with operative cholangiography in which there was no exploration of the common duct, but the entire pancreatic ductal system was visualized and suggested that possibly we used too much pressure. In neither of these 2 cases was the complication serious, nor did it prolong the hospital stay. 2 were where stones were easily removed from the common duct without trouble. And as is our custom, the sphincter was probed for patency and irrigated through the patent Bacchus dilators that we have made patent. And a completion operative cholangiogram was taken. Therefore, it's a little hard to assess the real guilt between the 3 procedures, the dilatation, the exploration, and the operative cholangiogram. But here, too, these 2 cases were not fatal. They were not really too serious. But the other 3 cases were serious, 2 of them fatal, and were associated with an impacted stone in the common duct, 2 of which required duodenostomy and sphincteroplasty to recover the stone. I might say that in none of these cases has a long T-tube been used. We never use it, so it cannot be incriminated in these cases. I do think that one of these cases, the condition was not recognized early as it might or treated as heroically as it might have been. Therefore, I would say that the thing that we should remember is a prompt recognition of the condition, and this would entail, I think, to get it really early, prompt postoperative serum amylase, particularly in those patients in which the sphincter has been instrumented or in which operative cholangiography has shown the length of the pancreatic duct. The treatment should, of course, be that for acute pancreatitis. And the fatal cases are always, we have cardiopulmonary complications, renal failure, ileus, and shock, and therefore all these conditions have to come into the picture in the treatment. Now, about bile drainage, there were 2 cases of bile peritonitis, and one of these was fatal. The Drainage of bile from a wound site is something to be of concern, I'm sure. And when it drains around the T-tube, it should be of concern, or when it drains profusely from the T-tube and prolonged, it is a concern. Now, some of the things that can be the origin, of course, the source of this drainage is an anomalous duct in the liver bed that we didn't recognize. Even sometimes you close these, they'll still drain. Never failed to drain bed in which we've seen, even though we've closed an anomalous duct. Poor ligation of the cystic duct stump, a poorly seated T-tube in the common duct, and of course a prolonged drainage from the common duct can come from a pancreatitis or from an overlooked stone. And of course I didn't mention stricture in this company, but of course an injury to the common duct can cause this too, and or jaundice, as well as profuse drainage of bile. We prefer, when we drain the subhepatic space, to drain it with a suction drain. As Dr. Collar, now deceased, said, bile has never gone to college, has never learned to climb a Penrose drain. You have to suck it out. And if we're going to incur the premium of the untoward sequelae of drainage, I think we ought to at least get the full dividend, and I think that means that we should have a suction drain. I have always followed a policy of closing the duodeno-hepatic ligament around a drain or afterwards, feeling that any bile transudate does not dissect up around the bile duct and is irritating to the bile duct could cause inflammatory stricture of the full length of that duct between the two organs, the liver and the pancreas. Now, there were several other complications in the field: hemorrhage, dehiscence, and abscess. As far as hemorrhage is concerned, there's one thing that we may not think about, and where we retract the liver, the retractor can dislodge the capsule and create a subcapsular hematoma. If this isn't lanced, it can continue after operation to dissect and lose blood from the circulation under the capsule. I know of one case of a friend of mine, and he had to go back in. So always look after you've retracted the liver, and if you see something like this, just incise it. It'll stop bleeding immediately. As far as wound separation, I think that we don't have to go to enzymes or vitamins and to blame them. I think it's usually a poor technical closure, and sometimes we can blame our partner in crime, the anesthetist, for not relaxing the patient, and I think the veteran will always just wait until the patient is relaxed before he closes a wound. Pulmonary complications, particularly to be thought of in the smoker, and abdominal distension are some of the contributing factors. As far as wound infections are concerned, I would like to only make 2 points. Of course, the first is the matter of protecting the abdominal wall itself. It is more vulnerable to infection than is a peritoneum. It can't resist it or handle it as well, and therefore we should have some sort of protection of the wound, and we have gone, I imagine most of you have, to this circular V-drape, which is easily inserted and takes up less room than the previous gauze packs that we used to use. I would like one other word about infection, and I think this is the most important, and that is that where we find frank pus in an abdomen, we should always think, I think, of delayed closure of the fat and skin. Close the fascia if you wish, should probably, but pack the skin and fat open for a delayed closure, or let the wound close itself. It means a few more office strips for dressings, but it'll always close just as neatly. And this is particularly true in the fat abdominal wall. But where you've encountered real pus and empyema of the gallbladder, I think this is a real life-saving measure sometimes, because then we don't have a wound infection that we don't recognize for a few days late. Then, in closing, I would simply summarize, Mr. Moderator, that of the 7% of complications, exactly about half originate in the surgical field, a half outside the surgical field. I have not mentioned these because Dr. Muller is going to take care of them. And the mortality was a little bit greater in the cardiovascular group.
Bill Sandusky will discuss infectious complications of surgery. Bill?
I'm sure all of you know that the common complications following operations are urinary tract infections, pulmonary infections, wound infections, and to a lesser extent, septic thrombophlebitis. But I dare say that many of us have looked into, as I had not up until a few weeks ago, the incidence of infection as a cause of mortality on a surgical service. And if we had a show of hands, which I'll not take a vote on, I wonder if you would say that infection is responsible for 10% of the deaths on a general surgical service, or is infection responsible for 90% of the deaths, or is it somewhere in between? And in a form of sort of self-examination, I looked into the hospital records. I searched these myself of the last 100 patients on our surgical service, the general surgical service, the last 100 patients that had died while in the hospital, and assessed these from the standpoint of infection. The general surgery service of our hospital includes thoracic, cardiovascular, plastic surgery, and also admits patients with multiple system trauma, as well as the conventional general surgical cases. These deaths occurred over a period of approximately 63 months. There were 100. These represent 5,000 admissions to the general surgery service. Now, of the fatalities, 63 showed no evidence of infection, and 37, and all of these figures, of course, will be in percent because we started out with 100 deaths, 37 were associated with infection in some way. Of these 37 infections, we have divided them into 3 categories. By incidental infection, one means the patient who, during the course of hospitalization, had some trivial infection that had no influence at all on his demise. For example, a urinary tract infection, a simple wound infection. The patients that we call terminal pneumonia are 5 in number, and a typical example of what we mean here is a patient who is admitted with some incurable process. For example, a patient with advanced mammary carcinoma, extensive osseous metastases, who really comes in the hospital only to die of bronchopneumonia, which leaves us with 25 patients in whom I thought that infection was the primary cause of the patient's death. Now let's look at these 25 in a little more detail. 11 of them had infection at the time of hospitalization. Infection developed prior to hospitalization. And 14 developed infection following some form of surgical procedure. The causes of death categorized in some logical groups. Peritonitis and intra-abdominal abscess leading the list, responsible for 10 of the 25 deaths. And then gram-negative septicemia, responsible for 5, pneumonia 4, lung abscess 3, mediastinitis, tetanus, and leg gangrene, responsible for the rest. Now we can look at these a little more closely to see what sort of conditions led to the development of peritonitis or intra-abdominal abscess. Now there were 2 bowel resections and 1 colostomy. Both of these were for patients who had acute intestinal obstruction and had to be operated upon in a state of unpreparation for sepsis. The 2 peptic ulcers with perforation came to us already perforated, very sick with peritonitis. Neither one of them came to operation. Both of them died promptly after admission. The rupture of the stomach is interesting. It occurred in a 2-day-old infant, and the patient was admitted already having had peritonitis at the time of admission. Cholecystitis with perforation was a patient admitted 2 weeks after the perforation had occurred, and he died. The gangrenous appendix with perforation, the abscess was localized. The patient died 2 days after operation while he was undergoing endotracheal suction. He had a cardiac arrest, terminated fatally. The splenectomy and coronary vein operation was a very complicated patient with cirrhosis who survived a number of complications, only to die with a large collection of pus in the peritoneal cavity, which was unsuspected at the time of autopsy. And this is a clear example of masked infection obscured by the use of antibiotics. And there was one in which we don't know what the etiology was. I was surprised to find only 5 cases of gram-negative septicemia as a cause of death. In connection with gram-negative, I would say that overwhelmingly in all of these patients, gram-negative organisms predominated. About 2/3 of the organisms that were cultured were of the gram-negative order, and the gram-positive ones being much, much less. The pneumonias, one was a renal transplantation who at the time of his demise had less than 400 white blood corpuscles. The patient with a patent ductus arteriosus was a gram-positive pneumococcal pneumonia, something that we see rarely these days. The bleeding duodenal ulcer was a patient with advanced pulmonary tuberculosis whose bleeding ulcer responded very nicely to cooling, gastric cooling, but he died of a bacterial pneumonia in the post-operative period. The miscellaneous ones, 3 lung abscesses, 1 case of mediastinitis, and I would just remind you that we still see patients who have tetanus in our part of the country, and some of these people with tetanus die. Here then, I think, is a group of patients, at least a quarter of whom met their demise as a result of complication which could be traced relatively directly to infection.
Pardon me, gentlemen, for just one moment to signal the end of Side A. Side B, featuring Dr. William H. Muller's discussion on cardiopulmonary complications in surgery in the aged, and a question and answer session, may be heard by just flipping over your recorder's cassette or 2 reels. Side B, Audio Digest Surgery, Volume 17, Number 16, continues a program on common complications in surgery. Once again, our program moderator, Dr. Curtis P. Arts.
And now the final presentation on a topic that I think is of interest to all of us, and that is cardiopulmonary complications in the older patient. I think we're all scared that we're operating upon people who are older and their cardiopulmonary status might not be very good. And I think it's wonderful that Harry Muller will talk on cardiopulmonary complications in these people. Harry?
With the advent of Medicare in 1965, there were 18 million people over the age of 65 years. And the following year, the figures showed that there were about 3,200,000 over the age of 80. The official tables for a patient 80 years of age indicate that this patient can expect to live 6.7 years longer. And if you're a female, you can live a bit longer than that. This age group has been increasing rapidly in number since that time, and one can expect more of these patients to come to operation. And it's in this age group that one has the highest complication rate, not only cardiopulmonary, but others. At times, with the older patient, there's a tendency, I think, for the surgeon and the anesthesiologist to treat him as any other patient, and this is a mistake. This patient will develop all of the complications that the younger patient will, but in addition, he will frequently develop more. The older patient has a much greater possibility of having pre-existing renal or liver disease. He's more likely to have diabetes. He can not tolerate trauma as well as the younger individual. Wound infections are more likely. His nutrition is often poorer, and he heals his wounds at times poorer than the younger patient, and therefore one can expect that he will have dehiscence of his wound more frequently. And in general, the hospital mortality rate for older patients is significantly increased. Now, this is not to say that we can't operate on the older patient today with the greater safety than ever before, but it is to say that one must be aware of the greater likelihood of organ and system deficits and the fact that this group of patients will have a higher postoperative complication rate in spite of the most careful preoperative evaluation and postoperative care. I chose from the literature 2 series which I thought were interesting, one over the age of 75 and one over the age of 80. And because as I get older, I don't know what elderly really means, and I wanted to make sure that I was dealing with elderly patients. Now, the pre-anesthetic complications that one can have, the cardiovascular problems are considerably greater and the respiratory problems are considerably greater than any of the others. So even before you start to operate on these patients, you have complications. The type of anesthetic is also important, and various series indicate statistically that the mortality rate is significantly less when the operation is performed under local anesthesia than when a general anesthetic is employed. However, I think one has to assume that generally the operation under local anesthesia is usually of less magnitude. Regardless of the anesthetic, when a major operation is performed, one has to anticipate that the probability of complications will be greater in this age group. Now, as has been, I think, the theme through most of the addresses that you've already heard, the most common group of complications are those involving the cardiorespiratory system, and in fact these make up more than 50% in all of the series that I looked at. Now, the series from the St. Vincent's Hospital in New York, I would like to particularly point out the pulmonary complications and the cardiac complications. Many of these are not particularly severe complications. In these 516 patients, there was overall rate of 25.2%, but in the pulmonary and the cardiac complications, 12 had bronchial pneumonia, there were 7 had pulmonary edema. Pulmonary embolism occurred in 6, and I think one has to always think about the development of venous thrombosis in these patients and pulmonary embolism. And atelectasis occurred in 5. In one patient was a small unsuspected carcinoma of the lung. In addition, 13 developed congestive heart failure, and 6 had myocardial infarctions, 1 a cardiac arrest, probably as a result of an infarction. And all of these complications occurred in spite of careful cardiac assessment. And another series, the one patients over 80 from the Harvard General Hospital in Los Angeles, a series of 710 patients. The incidence of complications was about the same, about 27%. It was found that when 2 operations were performed, the complication rate in this group of patients at least was no higher than when 1 was performed. But if one performs 3 or 4, then the percentage of deaths, and this obviously reflects complications, doubles. So that it's important not to operate on these patients more than one has to at one sitting if you can possibly avoid it. Number of cardiorespiratory complications in these patients. Again, the cardiovascular patients constitute the greatest number, and the patients who are over the age of 80. And I think that this emphasizes, again, the necessity of a careful cardiorespiratory evaluation before operation. This is certainly possible when elective surgery is planned, but obviously it cannot be accomplished with any degree of accuracy in the patient with acute trauma, which we see more and more frequently, these patients involved in highway accidents. Now, particular attention should be given to the cardiac status of these patients. Many of them are digitalized before you see them. If not, most of them, these patients 75, 80 or older, should be digitalized, and diuretics should be given when indicated. Pulmonary complications can be reduced, I think, if one has the time to place these patients on a careful respiratory regimen, certainly try to stop the patient from smoking, carefully evaluate his pulmonary status by pulmonary function tests, and in the postoperative period, the use of frequent endotracheal suction, chest physiotherapy, which we think is very important in managing these patients. And in addition, we use intermittent positive pressure breathing both before and after the operation, and before operation to really teach the patient how to use this apparatus. And it is important, I think, in the postoperative period in helping the patient to expand his lungs and to help prevent atelectasis. In combination with this, of course, bronchodilators may be helpful, and mucolytic agents may also be helpful. In many of these patients, they are debilitated, they have difficulty breathing, and just the work of breathing is quite a task for them. And times it's necessary to use assisted ventilation. I can't overemphasize the necessity of endotracheal suction with assisted ventilation, keeping the trachea and the bronchial tree as clear of secretions as possible. And also, I would like to emphasize the necessity of the sterile intubation, or sterile endotracheal suction, because certainly one can transfer infectious organisms, and if one does not do this, then the incidence of pneumonia is increased. We have been especially impressed with the use of a volume control ventilator, although I know that others have not thought that this was necessary, but we believe that these patients can be maintained on assisted ventilation for a longer period of time if a volume control ventilator is used. Now, if the patient cannot raise secretions properly, then one may be forced to perform a tracheotomy, and this is often very helpful in maintaining a tracheal toilet, in addition to the assisted ventilation that may be required. Now, another point that I think should be emphasized is that many of these patients have a reduced blood volume. And if this is not taken into consideration, these patients are more likely to go into shock, to develop myocardial infarcts in the postoperative period. And therefore, hypovolemia should be corrected before operation. And certainly, proper maintenance of blood volume should be instituted after operation. But in the postoperative period, one should be especially careful about overloading the vascular system in these patients in order to prevent the development of congestive heart failure. As opposed to the opposite pole of life, the older patient is fragile. However, one can operate upon him and perform procedures of great magnitude with amazing success. On the other hand, I think one has to be prepared to accept a higher number of complications, and many of these will be in the cardiorespiratory system.
Now, there are some good questions sent up. The first one, Dr. Hallenbeck, talk about opening of the stoma. I think we all have stomachs that refuse to open, and this is a bug. Now, you talked about this nice drug, urocholine. You give pretty good-sized doses?
I've started off with it parenterally in doses of about 3 or 4 milligrams, and that's almost always not enough, but occasionally someone's a bit sensitive to it. And usually we get up to 5 milligrams subcutaneously, and then soon get on oral dosage, and the commonest one that seems to work is about 10 milligrams, 3 or 4 times a day. It's enough to give a little sweat and sometimes a trip to the bathroom and some cramps, so you know that you're having at least some generalized effect of it. I haven't ever seen any kind of a study that would tell us whether this is really doing any good. You'd have to, every other case, something of this sort, to find out whether we're just doing something dramatic, because it is a bit dramatic to give it, or whether we're really helping.
I think this has been fairly effective. At least it's something to do while you're still waiting another period of time. Now, the stoma hasn't opened. You said 2 weeks. Oh, gosh. What will you do on the 28th day? That's what I want to know.
Well, there's always the possibility that it's organically obstructed. I haven't seen too many like that, but I can recall one case in which it was a Billroth 2 operation in which the efferent, or distal loop of jejunum, had folded back and become attached to the anterior surface of the anastomosis. It was like kinking the garden hose. And then if you do posterior anastomoses, there certainly have been reports of herniation of a loop up through behind the colon. This could give an organic obstruction. And sooner or later, I suppose you have to go in and have a look. And how long you can wait, I should think, would depend not on some predetermined number of days, but on the condition and age of the patient, nutritional condition, as to how long you're still going to have somebody you could operate on if you had to with a reasonable risk. And that would be a matter of judgment as well.
Dr. Baker?
When you do go back in on this 28th day, because I think you'd be inclined at this time, I wouldn't be quick to change the anastomosis, as Dr. Hallenbeck said in his opening comments. In the old days of gastroenterostomy, we'd see this. And if you went down and took the gastroenterostomy down, you'd often kill the patient. What you want to do, you do want to make sure it's patent. And you'll find that it is patent, by and large. There's an exception to the rule. But if it's patent, don't bother with it. Do a jejunostomy for feeding, because these patients need whole food. Now, this may not be quite as necessary now that we have better parenteral feeding. I haven't had any since we've had a really more caloric and protein feeding that we have now. But in the old days, that was the thing to do, is to do a feeding jejunostomy and give them whole protein food, which we couldn't give before. And the edema of the stoma was really motor, apparently. The achalasia, whatever it is, rights itself and the patient isn't starved in the meantime.
Dr. Hellenbeck, do you use a nasogastric tube? Now, this isn't all gastric surgery because I think it pertains to this, huh? Or do you use gastrostomies or both?
Where the operation lets me do so, I like the stam gastrostomy and use it frequently. Sometimes it seems hard to get that out in a certain body build, apart from through the incision or something of this sort, and do use nasogastric suction. Vagotomy is so much a part of so many operations now, and I think all of you will remember when it first came along, Dr. Dragstead warned us that you needed to have the stomach decompressed by suction for 5 days, and we started to do that, and patients complained bitterly. Pretty soon the residents were doing it for 4 days and not bothering to tell me about it, and everything went along well, and then for 3, and finally down to about 2, and now I know some surgeons who, if the rest of the operation involves a partial gastrectomy, don't even use a tube, despite the fact that vagotomy was a part of the operation. Bill Remind's an example up at the Mayo Clinic, and he tells me it works fine. Only add one thing: if you do let that vagotomized stomach get really distended, you are in bad trouble.
I don't know. I haven't been impressed with this heroic no-tube stuff. I don't know. Bill Sandusky?
Well, I guess it's a bad thing to say you always do something,
No,
but I really, if I operate on the stomach, I always do put some kind of a tube down. Most of the time, it'll be a nasogastric tube, and occasionally, depending on the patient's general status and whatnot, it will be a gastrostomy. And my practice is, if we do the vagotomy, to leave the tube in a long time. You know, this archaic stuff, Curtis.
Dr. Baker, those gallbladder surgeons, after a common duct exploration with the assurance of patency by dilators and irrigation, operative cholangiogram shows no stones, but the dye won't go in the duodenum. What do you do now?
I think this is true in about 30% of the cases, because I think when you open a common duct, you're obligated to ensure its patency into the duodenum. This means you probe it. This means spasm. With this completion operative cholangiogram, you can press proximally and try to force it through and see the detail of the sphincter then. I think this is one of the reasons it's important to get a pre-exploration cystic duct cholangiogram to know the function of the sphincter beforehand, too. But this will happen in 30% of the cases if you don't apply proximal pressure. Therefore, I would not say that this was a stone at all. I think then the post-operative cholangiogram you took in the 3rd, 4th, or 5th day would show a normal emptying. All right.
Now, the next question in this same area. Would you do an operative cholangiogram in a patient in which the gallbladder contains a large stone, too large to pass the cystic duct, and which in itself was quite small, a cystic duct, making operative cholangiography difficult if you wanted to pass a tube down? In other words, here's a small duct and a large stone, no other signs. Now, are you a routine operative cholangiography man, or would you say, gosh, that patient's all right if the duct isn't enlarged and she hasn't been jaundiced and no pancreatitis?
Let me ask you, if 6 months later this patient had angina in the middle of the night and you're the cardiologist that inherits the care of this patient, would you feel a little bit better to have a visual picture of the entire biliary tree, of which the gallbladder is only a part, that you can look at and say, well, yes, I'll treat the heart because there's no overlooked stone in this case? I think the surgeon who's doing biliary tract surgery in today's world of surgery is sort of obligated to provide this visual record for the fellow who's going to inherit the care of that patient. I have found stones in the common duct when there were none in the gallbladder, and I'm sure you have. So there is no all or none about this. I think it's absurd to ask a small community hospital, which he doesn't have the cooperation of the radiologist, and who he cannot possibly perfect the same quality of film in the operating room as he can in the x-ray, that he can't depend. It's confusing. You don't get the same quality or as good interpretation. But I'm talking about in a referral center that can do open heart surgery. I think they should be able to do routine operative cholangiography. As far as the dividends or rewards of operative cholangiography, in our studied cases, half of our staff do it routinely and the other half don't, so we had a good comparison. But by cystic duct cholangiography, We avoided the unnecessary expiration of the duct in 373 cases in the face of compelling indications in 175 of them, and these were followed 5 years later to see if we missed stones. And in the patients with small gallstones in the gallbladder, which we think may be an indication, but here was where the high incidence of negative expirations occurred. We avoided those expirations here. But the interesting thing is that we found unsuspected stones, absolutely nothing suggested, no alkaline phosphatase, no history, in 6% of these in which we had done routine operative cholangiography. And, of course, the completion operative cholangiogram, I think most of us agree with. In 7 cases, the doctor was tired and didn't observe the positive interpretations at all. It's an artifact. 2 of these had to be reoperated on. This is our technique of doing it. We insert a catheter, a long polythene tube that can stretch out of the field, into the cystic duct. With the tie that we use on the cystic duct stump, we reinforce the other tie with to stabilize the system. Then we use just a routine polythene as a rule. If we have any trouble cannulating, as the case you mentioned, we resort to the specially made polythene tube, which has a more rounded tip and is a little easier to get in, but it's a little bit of extra expense that we don't use routinely. Then when you do the completion cholangiogram, I think it's important to put the polythene tube down through the T-tube and irrigate so that the air can egress around the polythene tube as well as through into the duodenum, and you're less apt to have retained air to confuse you, instead of just placing the injection syringe right on the T-tube itself.
Dr. Sandusky, what do you do to prevent, if you can, or usually to treat Clostridial myositis in the occasional patient you see that develops it in the abdominal wall after biliary tract surgery?
I've only seen very few cases of true Clostridial myositis of the abdominal wall. And the ones that I've seen have been not after biliary surgery, but in the lower abdomen. And, well, let me be more specific. I've only seen 2 cases, and both of those responded very satisfactorily to radical debridement of the muscle, disregarding any sort of a herniation that might follow in either one of these individuals. And both of these individuals survived the infection. And, of course, obviously, they receive appropriate support with antibiotics, transfusions, and such like. But I think it's essential that when you do have Clostridial myositis, you don't depend on drugs alone, but that you clean up all the dead and dying muscle, because that's...
And not be afraid to cut it.
I don't think, well, you, like the old fella said, you know, better have a live lamb than a dead lion, and I would disregard any sort of a hernia or anything else that you might get. You want to get this fellow well, you can work on the rupture later on.
Later.
George asked me a question, whispered in my ear,
yes, sir.
In response to this clostridial question, and he said, what about hyperbaric oxygen? And I suspect maybe that's what somebody wanted to hear about. Now, if you will read the literature from Holland, you'll see that those people who use hyperbaric oxygenation combine it with the usual appropriate therapy, namely amputations and antibiotics, et cetera, et cetera. And I just don't have any real faith that breathing overpressures of oxygen is going to deliver oxygen to this dead and dying tissue. A long time ago, I did some experimental work with actual putting of oxygen-releasing substances, namely zinc peroxide, into the area of the wound, and that doesn't do any good either, Curtis.
I think Dr. Muller emphasized what we've seen and try to point out at our service conferences each Friday, and that is you can really operate upon the older patient, but if he has a complication, he's just twice as much trouble, and his chances are only about 1/2 that of a younger individual. In other words, that older, brittle fella will withstand the operative procedure, but boy, when he develops a complication, he just won't withstand it like somebody younger. I still don't know what to do, Harry, with that myocardial infarct patient. What do you suggest for the fellow who has had a myocardial infarct 3 months previously, and you've got to operate on him because of acute cholecystitis? Now, I know you're not going to operate very long, because you probably, in a fellow like that, go in, scoop his stones out, and do a cholecystostomy. But is there anything you know you can do for that fellow that's had a myocardial infarct when you have to operate on him?
Well, I think by the end of 3 months, his cardiovascular status should be in about as good shape as it will be. You take all of the precautions that you would otherwise. You would make sure that he was not in congestive failure if possible. You can digitalize these people rapidly, and as I mentioned, I think digitalization is very helpful in them because some of them have cardiac reserve that is critical, and the administration of digitalis may make the difference. I think that blood volume should certainly be considered, that you should be sure that this patient is not hypovolemic, and then I would go right ahead and operate on him. I think that if you consult with your anesthesiologist and you are cognizant of the fact that this patient has had a myocardial infarction, that he may be more likely to have some sort of cardiorespiratory complication, you consider this, you do the operation, you do the least you can, as rapidly as you can within reason, then this is about all you can do, I think.
Hope that anesthesiologist gives lots of oxygen and lets you know if that blood pressure begins going down. You have the same fear as many of us that chance of another myocardial infarct is much, much, much greater if that blood pressure is down below 90 for a period of 15, 20 minutes?
I don't think there's any question about this. There is a greater chance, and I think there's been some interesting work recently to indicate that what really happens in these narrowed coronary arteries is that the vessel or the tissue beyond them becomes ischemic, that the artery becomes thrombosed beyond it, and this is the cause of the infarct. And so I think it's very important to maintain coronary perfusion throughout the procedure, and this can be done, as you imply, by maintaining an adequate blood pressure.
Please comment on the use of low molecular weight dextran as a measure to minimize the risk of postoperative coronary occlusion or thrombophlebitis or pulmonary emboli. And does the risk of vascular overload using this in elderly patients upset its prophylactic benefit? In other words, do you think that dextran prevents the formation of thromboembolic disease? And if you do you think that giving it might overload the vascular system because of its plasma volume expanding powers?
Well, I really don't know whether it prevents thromboembolic disease or venous thrombosis or not, and I'm not aware of any really good figures that are available to support whether it does or not. I know that low molecular weight dextran has been used fairly extensively. It isn't an anticoagulant, as you know, in the sense that heparin is, but I think it exerts its influence by preventing the agglomeration of red cells, and is particularly useful, I think, in maintaining capillary blood flow and arteriolar blood flow. I would much prefer to put elastic stockings on these patients to get them up as quickly as possible and ambulate them and use measures such as this. Now, I don't think there's any question that dextran, given improperly and particularly given too rapidly, can overload the circulation, and again, particularly in the older patient, and throw this patient into cardiac failure, just as one can with the administration of too much of any kind of fluid. But the clinical dextran, which has a much larger molecule and perhaps is gotten rid of a bit slower, and I think is used more frequently, may be even more prone to do that. The point I would make is that I think that if you administer any colloid or crystalloid solution, you should do it carefully and with, I think, emphasis on the temporal aspect of it.
I'm like you. I really don't know where we stand in this world on this. I don't think there's any real evidence that low molecular weight dextran prevents thromboembolic complications in older people, in spite of how much we'd like to believe it might, or that there was something that would do this.
Thank you, gentlemen. And this doctor concludes the 16th edition of Audio Digest Surgery 1970, produced twice each month by the Audio Digest Foundation as a non-profit subsidiary of the California Medical Association. Until our next issue, thank you for listening.